Hello, hi. I'm Dr. Hussam Gouda, one of the consultants in obstetric and gynecology. In this video, I will talk about CTG in practical perspective, and I will cover the features of the CTG and how to categorize these features from reassuring, non-reassuring, and abnormal features, and the interventions needed to be taken in each category of the CTG, and will apply our knowledge at the end of the video by seeing different traces of the CTG to test ourselves after reviewing these informations. The informations will given in this video is taken from NICE guidelines of intrapartum care. I will leave the link of the NICE guideline intrapartum care in the description of the video. First, before you read the traits of the CTG, you should confirm the ID of the patient name, and the patient hospital number, and also the date and the time taken for this trace. And also, you should confirm the calibration of the machine. Usually, the calibration of the CTG machine is 1 centimeter per minute. And then also you should not make a decision regarding the patient relying only on the CTG. CTG is one of the parameters, one of the features that judge your decision. You don't, you should not do a decision only depending on the CTG only. You should see all the clinical situation of the patient, and the CTG is one of these aspects. These are the two pills that put on the abdomen of the mother, containing two transducers. The upper transducer is TUCO, that measure the frequency and the amplitude of the contractions. It's put on the fundus of the uterus. And the lower transducer is cardio, which detect the fetal heart rate. It's put on the area identified by the Pinard stethoscope or by handheld Doppler at the area of maximum intensity of the fetal heartbeats. And this is the trace of the CTG. It's composed of two components. The lower component representing the contractions, and the upper component is for the fetal heart rate. We evaluate the fetal heart rate for the four features: the baseline heart rate, variability, acceleration, and deceleration. Dr. C. Prevallo is a mnemonic that reminds you of the features of the CTG. DR, define the risk. C, the contractions. BRA, baseline heart rate. V, variability. A, accelerations. D, decelerations. O, overall impression of the CTG. DR, define the risk. Tell why you are doing the CTG. CTG usually is done in high risk pregnancy, like maternal causes, maternal risks, like a woman with medical disorders like diabetes, preeclampsia, hypertension with pregnancy, collagenic disease, systemic lupus erythematosus, sickle cell disease, thyroid disorders, or high risk baby, like baby with IUGR, oligohydramnios, or multiple pregnancy. Also, in high risk events that occur during labor, like vaginal bleeding or meconium stent leaker. Also, it's used in case of induced labor and in case of usage of oxytocin during labor. Regarding the contractions, we comment on the frequency of the contractions, how many contractions per 10 minutes. Normally 3 to 4 contractions every 10 minutes. If contraction is 5 contractions or more per 10 minutes, it's tachysystole and it's abnormal. And also we comment on the duration of the contraction and the amplitude of the contraction. If the contraction is lasting more than 60 seconds, it's called hypertonous contractions, and this is abnormal. Each feature in the CTG, we consider it as reassuring, non-reassuring, and abnormal. The baseline heart rate is considered as reassuring between 110 and 160. Non-reassuring if between 160 and 180, or between 110 and 100, and considered as abnormal if the heart rate increased more than 180 or decreased lower than 100. Variability. The variability is a fluctuation of the baseline heart rate to increase and decrease, and this occurs by interaction between the autonomic nervous system and the interaction between the chemoreceptors and the baroreceptors and the cardiac responsiveness. And so, presence of variability is considered as a sign that the baby is healthy. And the reassuring variability is between 5 and the 25 beat per minute. And non-reassuring variability if the variability reduced below 5 beat per minute, and this is accepted up to 50 minutes, or the variability increase more than 25 beat per minute, and this accepted up to 25 minutes. Considered also as abnormal variability if the variability reduced below 5 beat per minute more than 50 minutes, and also if the variability increased more than 25 beat per minute more than 25 minutes. Acceleration. Acceleration means increase the baseline heart rate more than 15 beats for more than 15 seconds. And the presence of accelerations means that the baby is healthy and is coping with labor. And the presence of acceleration is a reassuring sign. But absence of acceleration not usually means that the baby is unhealthy. Decelerations. Deceleration means decrease in the baseline heart rate more than 15 beats, lasting more than 15 seconds. And deceleration are different types according to its relation with the contractions. We have early decelerations that start with the start of the contractions and end with the end of the contractions. And early deceleration usually occur due to vagal stimulation, due to head compression. And usually it's reassuring and do not indicate any abnormality in the baby. We have late deceleration, which start after the end of the contractions. And we have variable decelerations. Variable decelerations are uh, not related to the contractions. And usually late deceleration and variable decelerations are usually caused by hypoxia and acidosis of the baby. Variable decelerations can be considered as reassuring, non-reassuring, or abnormal according to its duration and according to presence or absence of concerning characteristics. Concerning characteristics of variable decelerations are if the variable deceleration lasting more than 60 seconds, like this picture, the square in between the two limbs of the deceleration is more than one square. The square is 60 seconds. If there is no shouldering, if there is a failure or inability to return back to the baseline heart rate, or biphasic variable deceleration is concerning features, and also lack of variability during the variable deceleration also is a characteristic features. We have also acute events that may occur during CTG, like acute bradycardia or prolonged deceleration lasting more than 3 minutes. And these are signs of abnormal CTG finding and need urgent intervention. Coming to the overall impression after the CTG, we should categorize the CTG as normal CTG. In this condition, the intervention will be by continuation of the observation of the CTG, or by considering the CTG is suspicious CTG if we have one finding only non-reassuring and two finding reassuring. So the CTG is suspicious. In this condition, the intervention we will be reviewing the clinical situation to do conservative measures. Conservative measures is in the form of uh, correcting the underlying cause like hypotension or fever or hyperstimulation. So we'll give the patient fluids. We change the position of the patient, usually left lateral position. And if the oxytocin is going on, we will stop the oxytocin to reduce the stimulation of the uterus. And we review the clinical situation and reassess again after a period of time according to the finding present in the CTG. We have pathological CTG when we have one abnormal feature or two non-reassuring features. When we have pathological CTG, we will review the clinical situation and exclude acute events like rupture uterus, placental abruption, or cord prolapse. After exclusion of acute events, if the CTG is still pathological, we will start conservative measures, fluids, change the position of the mother, stop oxytocin, and review the reaction to the CTG. If the CTG is still pathological, we'll explain to the mom the situation and explain to the mom that we will do digital scalp stimulation, do vaginal examination, and digital digital scalp stimulation, and document the reaction. If there is acceleration, this means that the baby is healthy. If there is no acceleration and the CTG is still pathological, review the situation with the senior, with the consultant, and review the situation with the mother, and consider doing FBS, fetal blood sampling, according to the maternal preference to do fetal blood sampling or expediting delivery. In acute bradycardia or prolonged deceleration more than 3 minutes, usually we review the clinical situation to exclude acute events like placental abruption, rupture uterus, or cord prolapse, and start the conservative measures, fluids, stop oxytocin, change the position of the mom, and urgently prepare for expediting the delivery either by instrumental delivery or cesarean section according to cervical dilatation and presentation and situation of the presenting part, and also urgent asking for help from seniors. And while you are preparing for cesarean section or for urgent delivery, if the heart rate is resolved and return back to normal, counsel the mother if you want to continue observation and to continue vaginal birth or expediting delivery either by instrumental delivery or by cesarean section. FBS, fetal blood sampling. It's done in case of pathological CTG after exclusion of acute events because it's not logic to do FBS in case of rupture uterus, placental abruption, or cord prolapse. In FBS, we take blood sample from the scalp of the baby and measure the pH and bicarb. And the result of the FBS may be normal, borderline, and pathological. In pathological, we'll expedite delivery because the baby is acidotic and hypoxic. In borderline, we repeat the FBS after 30 minutes. In normal FBS, we repeat the FBS after 60 minutes. And we have 3 samples to be repeated. After the second sample, you should contact the senior, the consultant, and explain the situation and make an shared decision with the mother, either expediting delivery or continue observation of the baby. I hope this brief revision is beneficial for you. And all these informations are present in Intrapartum Care NICE guidelines. It's very important guideline. You can Google it It's created in 2019. It's present in Google search, and I will leave the link of this guideline in the description of the video. Now I will post some traces with different scenarios in the screen, and I will give you 10 seconds to observe the trace and tell your comment. And I will finally, after 10 seconds, I will comment on the CTG trace. This is a component of the trace of CTG. Lower part is for contractions. We comment on the contractions, frequency of the contractions, amplitude of the contractions, and the duration of the contractions. The upper part is for fetal heart rate. We comment on the four parameters: baseline heart rate, acceleration, variability, and decelerations. This is the first trace. I will give you 10 seconds to comment. First, we'll define the risk, why we are doing the CTG, define the risk, and then the contractions here is 3 to 4 contractions every 10 minutes. The baseline heart rate is 130. There is preserved variability. There are many accelerations, no decelerations. Overall impression of this CTG is normal. This is the second trace. I will give you 10 seconds. Okay, we'll define the risk, why CTG is done. Here we have 3 to 4 contractions every 10 minutes. Baseline heart rate is 130. Preserved variability. There are many accelerations. Only one deceleration is present in the trace. Overall impression, it's normal CTG. The third trace, I will give you 10 seconds. Okay, we will define the risk of CTG. We have 3 to 4 contractions in 10 minutes. This is example of reduced variability. You will see the line of the fetal heart rate is nearly straight line, no fluctuations. This is reduced variability, and the duration of the reduced variability will determine if it's non-reassuring or abnormal finding in the CTG according to the duration of this reduced variability. There is no deceleration, no accelerations. So this CTG may be non-reassuring or abnormal finding according to the duration of the reduced variability. The fourth trace, I will give you 10 seconds. Okay, we'll define the risk. We have 4 contractions every 10 minutes. The baseline heart rate is about 150, 140. There is reduced variability. and there is no acceleration, and there are many decelerations. You can see that the deceleration starts with the start of the contraction, and the peak of the contraction facing the bottom of the deceleration, and the deceleration end at the end of the contraction. This is the early deceleration. Usually, early deceleration is due to head compression, and it's considered as a reassuring finding. It's not usually a non-reassuring finding unless if it's associated with other abnormal finding in the CTG. So this is an example of early deceleration. The next trace will give you 10 seconds. Okay, we'll define the risk. We have 4 contractions every 10 minutes. Baseline heart rate is 140. We have here decelerations facing every contractions. And this deceleration start after the end of the contraction. When you see the peak of the contraction and the peak of the or the bottom of the deceleration, the bottom of the deceleration is following the end of the contraction in each contraction. The bottom of the deceleration is facing the end of each contraction. So deceleration occur after each contraction. It's an example of late deceleration. Next trace, I will give you 10 seconds. Okay, we'll define the risk. We have 2 to 3 contractions every 10 minutes. Baseline heart rates is 160. There is preserved variability. There is deceleration, which is variable deceleration. This is the shape of variable deceleration. You can see that the variable deceleration curve is biphasic or W-shaped, and there is shouldering of the heart rate before the beginning of the deceleration and after the end of the deceleration. There is shouldering, a slight increase, shooting increase in the heart rate of the baby, and this is good sign. This is a good sign. This variable deceleration can be considered as reassuring, non-reassuring, or abnormal finding according to its duration and the presence or absence of the characteristic features of the concerning characteristics. Next trace, I will give you 10 seconds. Okay, we will define the risk. We have here 2 to 3 contractions, 2 contractions every 10 minutes. Baseline heart rate is 130 or 120. There is prolonged deceleration, more than 3 minutes. Here, 1, 2, 3, 4, for 5 minutes. This is an acute event. Should do urgent intervention. Should exclude acute events like ruptured uterus, accidental placental abruption, or cord prolapse. Do conservative measures. Contact the seniors. Contact the OR to prepare for urgent cesarean section. If resolved within 9 minutes, you can consider expedition of labor or continue observation according to the shared decision with the senior and the mother. The next trace and the last trace, I will give you 10 seconds. Here we have two contractions in 10 minutes. Baseline heart rate is 140. We have here acute bradycardia. Acute bradycardia is an urgent situation like prolonged deceleration. We'll do the same. We'll exclude the acute events, ruptured uterus, placenta abruption, cord prolapse. Start conservative measures while we are preparing for urgent delivery, either cesarean section or emergent instrumental delivery. Communicate with the consultant. I hope I could make it clearer and simpler. And I advise you with training and reading the guidelines and see more videos and also training on the cases on the CTG will make it simpler and clearer in the future, inshallah. Thank you for your time. Thank you. See you. Thank you. Goodbye.